Hello, everyone. My name is Mark Durgan, the Project Director for the Pennsylvania Care Partnership, and it's my pleasure to welcome you all to today's webinar for our webinar speaker series provided by the PA Care Partnership in association with the Office of Mental Health and Substance Abuse Services. Information will be available at the end of today's presentations for those seeking continuing education credits for this webinar or a certificate of attendance. This information is also available in the email that you received from us today about an hour before the start of the event. Please note for the process, please note in the email that there's a process for the continuing education credits as it has changed if you had done this before for some previous webinars. If you have any questions for our presenter during the presentation, please type them in the Q&A feature, which you'll find along the bottom of your screen by running your mouse along the bottom, and you'll be able to see the Q&A and enter your question. We will get to as many questions as we can throughout the presentation, and we'll be conversing with Dan as questions come in that are relevant to the conversation at hand. Today's moderators are Nancy Massey, our social marketer, and myself, Mark Durgan. We'll be monitoring the chat and the Q&A. It is our honor to welcome today's presenter, Dan Dubovsky, an independent consultant and FASD specialist. He has worked for over 40 years in the field of behavioral health, and for the last 15, he was the FASD specialist for the SAMHSA FASD Center of Excellence. For his work in FASD, his son Bill has been his mentor and his best teacher. My pleasure to welcome Dan.
Thanks a lot, Mark, and thanks, Nancy, for having me. It's really a pleasure, and I'm happy to do that. And welcome to everybody who's on. I hope this will be helpful to you. Maybe get you to think about some things, maybe have a few ideas. And today I'm really focusing on some of the overall information, and then we're doing the second part in 2 weeks. We will focus more on, recognizing this, what do we do? And if I can be helpful to people after today, if there are any questions that come up afterwards, please feel free to contact me. The best way to contact me is by email. I live in Philadelphia, Pennsylvania. But if you want to send me an email, my email address is ddubovksy@verizon.net. So it's the reverse of the S and the K from my name, because I mistyped it when we set up the email. And once you do that, you're done. You can't change it. But I'm happy to talk with anybody and if I can be of help to people. As Mark said, this is the reason I got involved in FASD, fetal alcohol spectrum disorders, and it was about probably the first inklings about it were around 40 years ago. When my son Bill was about 7 years old, I brought him to a neurologist to try to find out why he was having some of the problems he was having. He wasn't doing well in school, and we have this, I happen to think it's a really not a great approach, where people need to fail at something in order to maybe get what they need. So I said he needs a small class, and they said, well, we'll put him in a regular education class, and if he doesn't do well there, then we'll talk about a different kind of class for him. So of course he failed in regular education class, and they put him in a small special education class with acting out kids, because he was acting out in regular education. And probably the worst class for a kid with an FASD is a small special education class with acting out kids. Because one of the things that we know in FASD is that most people with an FASD learn best by modeling the behavior of those around them. Not by being told what to do, not by being shown what to do, not by being consequenced for not doing what they're supposed to, but by modeling. So you put them in a class with other kids who are acting out, they'll act out and they'll follow the other kids, which is exactly what he did. He didn't do well with his peers in the neighborhood. And the clincher for me was that he didn't respond to my amazing parenting techniques. And I figured there must be something wrong with him. It couldn't possibly be me and what I was doing. So the neurologist did a cursory neurological exam and she said, does he drink? And I said, no, I don't think so. I hope not. He's only 7. Why would you ask me if he drinks? And she said, well, his reflexes are uneven. And usually that's indicative of drug or alcohol use in an individual or in their parents. And that was 1982. There was really very little I could find out about it. And I really looked. And for the next 7 years, we really struggled. He started gathering diagnoses like attention deficit hyperactivity disorder, reactive attachment disorder, oppositional defiant disorder. None of the treatments for those things seemed to be working. So he was labeled as being non-compliant, uncooperative, resistant, manipulative, and unmotivated. What I call NERMU. And my message is anytime you think somebody is being non-compliant, uncooperative, resistant, manipulative, and or unmotivated, stop and think, maybe there's something else going on that we're missing here. And so I was just, I was told, find the right motivating, find what he likes to do, and then use it as a reward for good behavior and take it away for bad behavior, which is the way I was trained also. I'm a clinical social worker by trade, and that didn't work. And so we just increased it and increased the things that I took away from him. And none of that seemed to work. And when he was about, so I was labeled actually, as he got older, I was labeled as being over-involved, overprotective, enmeshed, enabling, and unwilling to let go. And if I knew then what I know now, I would have said to people who said that to me, thank you very much for recognizing that. I hear that from a lot of parents who are told those kinds of things, especially as their kids get into adolescence and young adulthood. You're being overprotective, over-involved, enmeshed, enabling, and unwilling to let go. And I say the answer you need to give people is, yes, absolutely. Because if I'm not, my child will end up homeless, in jail, or dead. And we'll talk more about that. So in 1989, when Bill was almost 15 years old, an aunt of mine called me up one day and she said, I just read this book and I think you should read it. It's called The Broken Cord. And The Broken Cord is a book that was written by Michael Dorris, D-O-R-R-I-S. And Michael Dorris was a professor at Dartmouth College in New Hampshire. He adopted a child from the Midwest, brought his son home, had lots of trouble raising his son, couldn't figure out why his son had all the problems he was having, went back to the community from which he adopted his son, and they began to talk with him about fetal alcohol syndrome because they knew there were a lot of people in that community who had already been identified with FAS. It was the first popular book on FAS. Lots of people have read that book over the years and said it is so depressing because Michael only talked about all the problems he had with his son. He didn't talk about the joys. And if anyone knows the story, his son was walking along the side of the road when he was about 23 years old, and he was hit by a car and killed. I read this book and it was incredibly validating because everything in the book I said, ooh, this is Bill. Oh, this sounds just like Bill. And all of his behaviors, which for years were labeled as willful, purposeful behaviors that needed to be consequenced, finally began to make sense. And one of the stories I like sharing in the book, because it's so relevant in understanding FASD, is that Michael and his wife went out for dinner one night. They came home from dinner. There was an inch or two of water on the kitchen floor and water pouring down from the ceiling. Michael went upstairs to the bathroom. He opened up the bathroom door, turned on the light, and there was water pouring out of one of the pipes that was running along the floor in the bathroom. He went into his son's room. He woke up his son. He said, what happened? His son said, I didn't do anything. Good adolescent response from any adolescent. And Michael said, did you stand on the pipes and break them? And his son said, yes, but I did what I was told. And Michael said, what's that? And his son said, every time I leave a room, I'm supposed to turn off the light and close the door. And I did that. Now, if you don't understand FASD, you would say that his son was lying about what he did and covering up something he did wrong. And you would be absolutely wrong, and absolutely wrong to consequence him for that. Because for months and months, Michael drummed into his son's head, every time you leave a room, you turn off the light and close the door. Every time you leave a room, you turn off the light and close the door. And his son got it. And he couldn't figure out in this situation when the pipe was broken, he needed to do something different. Now, the reason that made a lot of sense to me is because I would come home from work, Bill would be nowhere to be found, and our door would be wide open. And we didn't live in a neighborhood where that was a great idea. So I said to him, Bill, every time you leave the house, you have to lock the door. I would come home from work, he would be out playing, he would come home, and the door would be unlocked. He would come home, and of course, I would consequence him for it, because clearly this was willful, purposeful behavior. And that went on for a long time. I kept consequencing him. He kept consequencing him, and he kept on leaving the door unlocked. And then finally, he did get it. And we went to take the garbage out, came back into the house, and the door was locked. You know, this is just an obnoxious adolescent trying to get back at me because I've been punishing him. Or we would go into the backyard, come to get back in the house, the door would be locked. And of course, what I know now, and what I knew after I read The Broken Cord, is that no, it wasn't that he was being obnoxious. It wasn't that he was trying to get back at me. It was he finally understood every time you leave the house, you have to lock the door. He couldn't figure out when you're this far away, you don't have to lock the door. When you're this far away, you do. Now, the ability to figure out what to do in a specific situation is a function of a certain area in the frontal lobes of the brain that's damaged by prenatal alcohol exposure. So you may tell your child, for example, every time you get to the corner, you need to stop and look both ways before you cross the street. And you may take your child out and practice that with them. Okay, we're at the corner, now stop, look both ways, make sure nobody's coming before you cross the street. You get that? And then one day you look out and they're crossing in the middle of the block without looking. And you could say to them, didn't I tell you to look both ways before you cross the street? And what they may say is, you told me that when I was at the corner, I needed to stop to look both ways before I crossed the street. I wasn't at the corner. So the behavior looks and feels so purposeful and manipulative, and it's not. It's damage in this area of the brain. In the same vein, I've done a lot of training for with women's substance use treatment programs for women who have their children with them. And in most of those programs, the young children go to daycare on the grounds, the older kids go to school, and the women have their groups during the day. And one of the groups that they have is parenting. And I've also done some training for child welfare in several states where, you know, they may take a child and place a child in kinship care or foster care, and then tell the parent that one of the things they need to do is go to parenting classes. Well, in both of those situations, for a parent who may have an FASD, it's the biggest waste of time, money, and energy that exists, because they can't take, just like I just said, they can't take what they learn in a parenting class and apply it 6 hours later or 3 days later when their kid is doing a certain thing. That's not laziness. That's not paying attention. That is a brain issue. So understanding that is really important. Now, this was around, as I said, Bill was around 15 years old at this point. And, you know, I began to really understand what was going on with him. It still took 4 more years to get a diagnosis for him. So he was diagnosed with FAS when he was 19 years old. And that meant 19 years of failing in every system of care. So I really thank Bill, because he taught me to think differently about behaviors. He taught me to help me understand what it's like living with this. I look back at some of the people I work with, especially as a therapist, who would come into my office, put their head down, pull their coat over their face, and I would write in their chart, poor eye contact, not motivated for treatment, not recognizing that some of them couldn't tolerate the fluorescent lights in my office. Fluorescent lights are really tough for many people with an FASD. They hear the buzzing in the lights. They see the flickering in the lights. They're too bright for them. They can't articulate that's what's bothering them. The kid in school who's bothered by fluorescent lights, because I've never seen a classroom that didn't use fluorescent lights. I never had an office that didn't have fluorescent lights. They may put their head down, crawl under the desk, jump out of their seat, run around the room, run out of the room, switch lights on and off, and be seen as just a disruptive child. And nobody will stop and say, I wonder if it's the lights that are bothering them. And then I think about some of the families that I work with. Now, I started out my career working as a direct care staff in residential treatment with children and young adolescents with mental illness in a residential treatment center in the middle of New York City. That was my favorite job. Absolutely loved it. I loved working with these youth. And then I went back and got my social work degree and worked as a therapist in another residential treatment center with children, adolescents, young adults and their families. And then did outpatient work for a while. I worked in HIV and AIDS for a while. I did training for people working in mental health and substance use services for a while. Worked in and supervised social workers in acute care locked psychiatric unit in a community-based hospital, and did some oncology work. So I think back to some of the families I worked with, especially in residential, where they would come to pick their loved one up for the weekend. And I would say, you know, here are their medications. This is when they need to take their medication. You need to bring them back on Sunday by 3 o'clock in the afternoon. Here's what you need to bring back with you. And here's what's contraband that's not allowed back on the grounds. And some families would bring their loved one back Sunday at 11 o'clock at night or Monday at 11 o'clock in the morning, and they hadn't taken their meds. And they brought back contraband that wasn't allowed. And I would write in the chart that these families were sabotaging treatment, not recognizing that I was setting some of them up by just giving them a list of instructions. And again, this is all has to do with understanding the brain and FASD, which is so important. So again, I thank Bill for teaching me what he has. Also, I put a picture of him up because nobody would see him in their program and nobody would meet him on the street and say, this is a young man with this disability. And for the most part, this is a hidden disability that nobody recognizes. And it is very painful to live with a disability where people have told you over and over and over again, you can do it if you want, you're smart, you're not trying hard enough, you're just lazy, you're just unmotivated. And they really do try and they can't do it on their own without the right supports. That is incredibly emotionally painful. And one of the ways to deal with that kind of emotional pain is to use substances. And it's not a great treatment, a long-term approach, but I understand why we're going to see a significant percentage of people with an unrecognized FASD, especially in our substance use treatment programs, because it's just intolerable to experience that kind of emotional pain all the time. When Bill got into middle school, he said, came home one day and he said, Dad, every day I walk into school, I feel stupid. Well, how many of us would put ourselves in a situation where we feel stupid every day? That's intolerable. Either get thrown out or truant, because you just can't do that every day. And especially when they get to middle school and high school, it gets to be overwhelming for them. So again, if it weren't for Bill, I probably would not be doing this webinar. I probably would not still understand FASD. So again, I thank him for that. For teaching me what to do. And that's why I'm from the do as I say, not as I did school of thought, because before I even recognized what was really going on with him, of course, I did lots of things that were wrong. And even afterwards, I didn't do everything right, but at least I tried to understand his behavior and what was going on and why. So the term fetal alcohol spectrum disorders was coined about 20 years ago or so, where a group of people got together, some people from federal agencies and researchers and some parents and some others, to come up with a term to convey the idea that this is a true spectrum of disorders that goes from mild deficits that are never picked up as due to prenatal alcohol exposure. So the person who maybe just had some trouble in school growing up, maybe they had trouble in social situations or in relationships or job situations, and it's never connected with the possibility of prenatal exposure. And otherwise they're doing well. The staff person who does really well working with people and never gets their paperwork in on time, even when they've been written up for it. May not be that they're just lazy or unorganized. It may be how their brain is working. So that's kind of one end of the spectrum. And the other end is fetal death and everything in between. So there's no specific dose response connection where this much alcohol exposure at this time during pregnancy has this result for everybody. There's also a wide range of intellectual abilities. So it used to be thought that people with an FASD had low IQ. And there is one study that found, a large study, that found that actually 91% of those with an FASD had an IQ over 70. And they've identified people with an IQ, the range being from about 29 on the low end to about over 140, which is genius level. So who still have brain damage and still may not be able to follow 3 directions at once and may not be able to read social cues because of the way their brain is functioning. And that's really important because people see somebody who is pretty bright, pretty verbal, looks okay. Because as I said with Bill, nobody would see him and say, oh yeah, he has an FASD, he has FAS. They look okay, they sound okay, they can repeat what they need to do. Clearly, all their behavior is purposeful. And when they don't do what they're supposed to, they need to be consequenced for it. So this, and the other thing is there's no way to predict how much alcohol causes how much damage in any individual. There are some experts in the field who 20 or 30 years ago were saying, well, 4 drinks a day is okay, 5 drinks a day is not, or 3 drinks a day is okay, 4 drinks a day is not. Not one of them would say that today, because we cannot say this amount of alcohol is safe for everybody, because everybody metabolizes alcohol differently. And even the fetus metabolizes alcohol differently. So how the person metabolizes alcohol has an effect on how long it stays in the system, how much of an effect it has. And one of the problems with alcohol, because it's always the unmetabolized substance that has the effect. It's the same thing with medications. It's what's not metabolized that has the effect. Once it's metabolized and on the way out of the system, it doesn't have any effect anymore. So some medications are metabolized very quickly, which is why you need higher doses or more frequent doses. So alcohol metabolizes to another active substance called acetaldehyde. So it stays in the system longer. And what happens is that, one standard drink for a woman who's pregnant, her blood alcohol level and the fetus's blood alcohol level are about the same, but her blood alcohol level drops pretty quickly and the fetus's blood alcohol level does not, because they can't process the alcohol in the same way. So 2 standard drinks for a woman who's pregnant may be more like 3 or 4 for the fetus, and 3 may be more like 5 or 6 for the fetus. And I'm not even at a Long Island iced tea yet. So there is no way to say this much alcohol is safe for everybody. And there are people who say, well, I drank during my pregnancy and my child's fine, so it's okay for you to drink during your pregnancy. Not necessarily. And again, FASD is not a childhood disorder. The effects don't go away at 18 years old or 25 years old or 55 years old. That doesn't mean that people with an FASD cannot do well. I know many people with an FASD who are doing very, very well. Those who are doing the best are those who have had some ongoing supports from family, from friends, from professionals. But lifelong disorder means that the brain damage is brain damage. And understanding that is really helpful in helping us, how do we deal with this? So the approach, recognizing that, is the approach for those with an FASD is not to change the person's behavior, which is our typical focus, right? That's why we use reward and consequence systems, to change the person's behavior. The focus in FASD needs to be to change the environment. We need to shift the environment to help this person be successful. And that's really the key, is how do we modify the environment for this person so that they can be successful and they can do well.
Dan,
yeah.
Before you jump into the next slide, we do have a question.
Okay.
It's given all that we know about FASD's impacts on the brain and the lifelong disorder, do you have any information or knowledge on Pennsylvania and the fact that FASD disorder is supported through the Mental Health Intellectual Disabilities Program um, I'm sorry, it's not supported as like the kind of longer term piece, but it's really supported through the behavioral health, which is more shorter term and outcome measured versus the longer term piece.
Yeah, I think the longer term approach is a better one. I think one of the things that has happened in many states is that, you know, we have shifted from the term mental retardation to the term intellectual disabilities, but we've taken the same criteria, which has to do with IQ. And the problem is, and then we also use the term developmental disabilities and often again applied eligibility of IQ under 70. And if we look at the federal definition of developmental disabilities, people with an FASD would absolutely qualify because it has to do with functioning. But as soon as you put on an IQ eligibility, most people with an FASD won't qualify for those services. And I think that they really, you know, they would benefit from those longer term services. And I think that there, you know, there really is this push to try to get Pennsylvania, other places to recognize that they need this long-term approach in order to be successful. And that not only do they need it, but it is cost effective. And that's a piece that you know, somehow our legislators, we haven't gotten that across to them because, you know, the economists have done studies on the cost of raising an individual with an FASD, and they have found that depending on which one you read, it costs between $1.5 million and $5 million US to raise one individual with an FASD. So anything we do to help these individuals and also to help in prevention, which I'll talk about, is cost effective. But we don't, you know, and we know that the earlier we recognize this and the earlier we intervene appropriately, the better the long-term outcomes. So, you know, I would love to see both, you know, both sides, you know, both the developmental disability side and the behavioral health side, you know, recognize this and recognize it early and in a sense almost work together to provide what's needed. But because it's lifelong, it's one of the huge problems is there are often many more services for children and adolescents. And then once they turn 18 or so, they're like cut off and there's not a whole lot out there. And we need to recognize that as adults, they need supports as well. So I hope that addresses that somewhat, at least.
I think so. It's I think it's kind of a goal and a work in progress.
Yeah. Okay. Thanks, Mark. And thanks for that question. Okay, so again, the behaviors we see in FASD look and feel very willful and purposeful, but our typical approaches don't work. And the typical approaches we use in every system, from parenting and school and treatment programs, is based on reward and consequence. And that just doesn't work with a lot of people with an FASD because their brain doesn't work that way. But we keep using those. We use the point, star, and sticker systems in school. And then parents of these young kids are told to use charts at home with points or stars or stickers. And these are the kids that get the fewest number of points, stars, and stickers. Because the idea of, if you want this, you need to do this now and get your points or stars or stickers. And they don't get their points or stars or stickers, but they don't understand why they can't get the reward. So we need to look at this, and that's why we need to recognize these individuals and modify what we do with them to support them. So not everything that a person with an FASD does is due to the FASD, because many of them have other issues, but also not everybody prenatally exposed to alcohol has an FASD. But again, we can't predict who will and who won't. But across the spectrum, from very mild to severe, we do see brain damage. And again, brain damage doesn't have anything to do with intelligence. And people think that brain damage means they're stupid in their thinking. And it doesn't. It just means some of the certain structures of the brain aren't working the way they should. And, so that piece about, again, well, this person drank during their pregnancy and their child is fine. then I can drink during my pregnancy and my child will be fine. Not necessarily. And not only that, but I drank during my first pregnancy and my child was okay, so I can continue to drink during my other pregnancies. Not necessarily so, because there are a number of ways that alcohol causes problems and causes more problems with more births. So again, we can't predict it. And I have a friend and a colleague who I met a number of years ago when her daughter was about 5 years old and had a diagnosis of FAS. And she had been in and out of substance use treatment for a number of times. And she said a couple of things. One is she said, nobody ever talked about the effects of alcohol in treatment. And she said, I don't know if it would have helped me stop drinking, but it might have. But the other thing she said was that, you know, in my culture, if a child is born with 10 fingers and 10 toes, they're fine. And all of my friends who drank during pregnancy said, my child is fine. They have 10 fingers and they have 10 toes. So it's okay to drink during pregnancy. The other thing that I have here is that people say, well, you're just giving people an excuse for bad behavior. And FASD doesn't excuse behavior, it explains behavior. And if it explains behavior, then it tells us what we need, what we can do to help. So every system of care is impacted by FASD, whether they think they are or not. And often, you know, I hear, no, we don't have anybody with an FASD in our system. And I say, yes, you do. You just don't know you do, because the vast majority are not diagnosed and maybe misdiagnosed with other things. But every single one of these systems, you know, child welfare is not only seeing kids in their system and adolescents who may have an FASD, but they're seeing adults in their system who have an FASD as well. And again, I think that's true in every single one of these systems. So, you know, I've run across school systems that say, no, we don't have any kids with an FASD. Yes, you do. And when we talk about what we see in the behaviors, they say, oh yeah, we have a lot of kids like that. And these are the people who are just failing repeatedly. So again, FASD is an umbrella term. It's a descriptive term in the United States. Now in Canada, FASD has become a diagnostic term. But in the US, it's a descriptive term. And that's why when it was developed, the people who developed it really insisted on putting an S at the end of the word disorder. In Canada, it was always fetal alcohol spectrum disorder, even when it was a descriptive term. In the US, it's been fetal alcohol spectrum disorders to convey the idea that this is a spectrum and this is a descriptive term. So under that descriptive term, there are a number of diagnostic terms that have been used. So fetal alcohol syndrome was coined in 1973 at the University of Washington, where they saw 10 kids who all kind of looked the same. They were all small in stature. They all had certain facial features. They all have certain cognitive impairments. And the one thing that linked all 10 of these kids together was that their mothers drank during pregnancy. And they coined the term fetal alcohol syndrome. Now, for those of you who may work in mental health, this is very different than any behavioral health diagnosis, which is often based on what we see. Like bipolar disorder is based on what we see. Schizophrenia is based on what we see. Fetal alcohol syndrome has nothing to do with what we see. It has to do with what's causing it, what the etiology is. So people think that, and then they also saw another group of kids who had the same kind of cognitive impairments. Their mothers drank during pregnancy, but they didn't have the facial features that they saw in fetal alcohol syndrome, and they coined the term fetal alcohol effects. That term isn't used anymore. It's been supplanted by these next three terms, really. But people think that this was identified in 1973. This is a new disorder. And there are people my age who will say to me, well, you know, my mother drank during her pregnancy with me because nobody ever talked about the effects of alcohol back then, and I'm fine. And if I know them well, I'll say, I'm not so sure you're fine. If I don't know them well, I might say, well, but just think whether you've had some difficulty with, you know, in some of these areas. Because we know that the effects of alcohol on a developing fetus have been identified for centuries. There is a statement in the Bible, in Judges, that says, "Behold, thou shalt conceive and bear a son, and now drink no wine nor strong drink." A statement made to Samson's mother when she was pregnant with Samson. There's a statement from Aristotle that children born of women who drank were like unto themselves, morose and languid. All the way through history, there has been identification of the effects of prenatal alcohol exposure, and we just never paid attention to it. Now, one of the things that happened in the 1960s, the late 50s and the 1960s, was there was a man in France named Paul Lemoyne who identified 127 children with what the term he coined was alcohol embryopathy. Their mothers all drank during pregnancy. And I think one of the key things, apparently that term didn't click with people because people didn't bother to use it. This was before the term FAS was coined, alcohol embryopathy. And but one of the things that he did, which I thought was so important, was that he followed these families, and some of these women got pregnant again and did not drink during their ensuing pregnancy, and those kids had none of the effects of alcohol embryopathy. So what he was seeing was that this was not genetically transmitted. This was not a genetic issue. This was an alcohol issue. So again, we've just known about it. We just didn't pay attention to it. In 1996, the Institute of Medicine published a volume on fetal alcohol syndrome, and they coined the term partial fetal alcohol syndrome for those who have some but not all of the features of FAS, of full FAS. They often don't have the growth deficits that are essential for the diagnosis of FAS. Alcohol-related neurodevelopmental disorder, or ARND, were those who have the cognitive issues but not the facial features of FAS, and that's the majority of those with an FASD really have ARND. So they don't have the facial features of FAS. They may have higher IQ, they look okay, and they get into more trouble. And alcohol-related birth defects for those who have the physical defects, things like curvature of the spine, scoliosis, or they may have certain heart defects. So those are the terms that are often used now, along with fetal alcohol syndrome. Now, fetal alcohol syndrome is the only diagnosis that can be given if we don't know maternal alcohol exposure, because they have not seen anyone who fits the rest of the criteria for FAS, which is 3 specific facial features. It's cognitive impairments, either structural, functional, or neurological impairments. So small head size, microcephaly is a structural impairment that would qualify, and the growth deficits. And they haven't seen anyone with those 3 facial features, the growth deficits and the central nervous system abnormalities, who did not have prenatal exposure. There are still places that won't diagnose full FAS even without confirmed maternal alcohol exposure, which makes it difficult to diagnose those who are in adoptive homes where they may not have birth history, or even foster homes where we don't have birth history. Sorry. And also hard to diagnose in adults who may not know birth history. The rest of the spectrum, you need confirmed maternal alcohol exposure. So up until the Diagnostic and Statistical Manual of Mental Disorders, DSM-5, came out, there was nothing in the DSM about the effects of prenatal alcohol exposure. And when the DSM-4 came out, I wrote a letter to the American Psychiatric Association asking them why this was not in the DSM. And the letter I got back was, the reason it wasn't in the DSM was because it never came up. And it's like, okay, well, then we need to make sure it comes up in the next DSM. And there are some families who have said, I don't want this in the DSM because then people will think that this is a mental illness. But the problem, having worked in mental health for many, many years, is that if it's not in the DSM from a psychiatric point of view, it doesn't exist. And then we don't look at what are the effects in terms of kind of behavioral health issues in FASD. So at least getting something in the DSM, again, then behavioral health can pay attention to it. and look at what is the impact of FASD on mental health treatment, and what is the impact of, of mental health treatment on FASD, or mental health issues on FASD. So we can begin to study that. We can begin to look at that and pay attention to it, which I think is just so important, because so many people have gone by with maybe they have a mental health diagnosis and we miss FASD. So when the DSM-5 came out, and up until the week before it was released, nobody knew whether there was going to be anything in it or not. There are two terms that are in the DSM-5. And the push from a group that was working with the APA, American Psychiatric Association, was this second term, neurobehavioral disorder associated with prenatal alcohol exposure, or NDPAE. There's a lot of good information about it in section 3 in the DSM-5, which is the section for syndromes for further study. There's really some very good information in there about NDPAE. The problem, at least in the US, is that does not have a code next to it, as you see. But in the body of the DSM-5, where everything's been restructured, and the first group of diagnoses are neurodevelopmental disorders. And one of them is other specified neurodevelopmental disorders. So we see autism is in the under neurodevelopmental disorders. High functioning autism, which used to be Asperger's syndrome, is under neurodevelopmental disorders. ADHD is under neurodevelopmental disorders. And then one of them is other specified, and each one has a code, as you see here, these numbers, which are really important because that's how you bill for treatment. And the example they give in the DSM for other specified neurodevelopmental disorder is neurodevelopmental disorder associated with prenatal alcohol exposure. So finally, we do have something which has a billable code where we can recognize that there are behavioral health issues that we need to address. And we need to address them differently if somebody has an FASD. So I was very excited when it came out. And every psychiatric diagnosis in the DSM-5 now has 2 numbers, because the first number there, like the 315.8, is the DSM code, the psychiatry code. And the one in parentheses, like here it's F88, is the corollary code for the International Classification of Diseases. Because HIPAA said once the ICD-10, the International Classification of Diseases, ICD-10-CM comes out, it will be the standard for all diagnoses, which means that's how you code diagnoses, and that's how you bill for treatment for diagnoses. So this is just in the ICD. Fetal alcohol syndrome has been recognized internationally, but it's been seen as a medical disorder. And now at least we see that there are some psychological issues that we need to pay attention to, and that's the F88. So people sometimes think that this is still very rare. And if it's so rare, we don't have to pay attention to it. The early studies by the CDC, the Centers for Disease Control and Prevention, whose mission is surveillance, were that the incidence of FAS was about 0.4 per 1,000 live births. Well, at that rate, it is so rare, we don't really need to spend money on it. We don't need to pay attention to it. The problem is the CDC's work is done through what's called passive surveillance. So in FASD, it was looking at hospital records and birth defects registries to get the level of FAS. And this is almost never picked up at birth, so it would never get into the hospital record. And it is almost, states have different kinds of birth defects registries. Not every state has a birth defects registry, but many of them that do only go up to age 1 or 2. And this is often picked up when these kids start school. It would never get into the birth defects registry. So we know that 0.4 per 1,000 is not really accurate. But that's how they looked at it. The other problem is that unlike other drugs of abuse, where now we have a larger focus and a more concentrated focus on what we're now calling neonatal abstinence syndrome, or NAS. And NAS is the withdrawal symptoms that you see in infants who are born addicted to drugs. And people start to begin to think that if we don't see neonatal abstinence syndrome, we're not seeing any ill effects of the drugs. But you would almost very, very rarely see any NAS in a child born with an FASD, unless it's been heavy alcohol use in about the 24 hours before delivery. You probably won't see NAS, and then we think this child is fine. And then that's why one of the reasons it's missed in hospitals. So up until recently, there had only been one active surveillance study, which is actually examining people in the United States. There have been active surveillance studies all around the world, just not in the US. So the National Institutes of Alcohol Abuse and Alcoholism, about 3 or 4 years ago, maybe it's more than that now, maybe it's 5 or 6 years ago, funded 4 active surveillance studies to identify the prevalence of FAS in the US. So they looked at, one is on the East Coast, one was in the Midwest, one was in the Rocky Mountain region, and one was on the West Coast. And they have been reluctant to label where these studies were done. But we know East Coast, Midwest, Rocky Mountain region, and West Coast. And Phil May, who has been involved in FASD surveillance since the 70s, was the lead investigator. And what they wanted to do was look at first graders, because if you're going to be able to see the facial features in FAS, the best time to see them is probably between about 5 and 8 years old. As kids get older, the face changes. It's harder to see these features. You could still measure them, but it's harder. So they wanted to look at, examine first graders. They had a whole diagnostic team, and they sent around consent forms to all parents of first graders in these 4 areas. And they got a little over a 50% consent rate. If I remember correctly, it was somewhere around 53% consent, but don't quote me on that. I think it's around there. So they examined these first graders, and they found a prevalence of FASD of between 1 in 88 and 1 in 20 kids. Now that's pretty significant right there. However, they found a weighted prevalence, and this is documented. This is in the published study, the first published study of these. The weighted prevalence was between 1 in 32 and 1 in 10. And the reason I think the weighted prevalence is probably closer to the accurate prevalence is because of this, because they only got about 53% consent, which means 47% of parents did not consent to have their kids examined. And we may guess that some of those kids would certainly might well have an FASD. Also, in one of the areas that these studies were done, the state did not allow the investigators to examine any kids who were in foster care. Well, we know that there are a lot of kids in foster care with an FASD. So that skewed their results to be much lower than they really accurately were. And the third one was, in order to give them a diagnosis of anything except full FAS, they needed to have confirmed maternal alcohol exposure. So they saw a number of kids who met the criteria for partial FAS or ARND, where they could not get confirmed maternal alcohol exposure. They couldn't give them that diagnosis. So my sense is probably the accurate prevalence of FASD is somewhere between 1 in 32 and maybe 1 in 20, maybe even more than that, but minimally that. That's much higher than autism. That's much higher than Down syndrome. And in addition to that, I think that there are a number of people being diagnosed with autism who really have an FASD, especially when physicians won't ask women about their alcohol use. And some things look like autism, so we'll just diagnose autism. And we'll talk a little bit more about that. So if that's the overall prevalence, then in our systems of care, it's going to be much higher than that. And our diagnostic capacity around the world really is minuscule compared to this prevalence, just minuscule. In Pennsylvania, we have one FASD Diagnostic Clinic that I know of, and that's in Philadelphia. We have some other physicians who are diagnosing this, but in terms of a multidisciplinary FASD clinic, we have one. Even in states where we have more clinics, because I do work with the state of Michigan, and they have 6 diagnostic clinics. Each one does different things and has different criteria, but even with those 6, they can't get to the number. There are long waiting lists, and they can't, it's still, the number of people diagnosed is really minuscule compared to what we believe the prevalence is. So most people are not going to be diagnosed with an FASD. And unfortunately, they're often going to be seen as having other kinds of issues. So I think for child serving systems, there are a lot of really important roles for any of you who are working in a child serving system. One is identifying a possible FASD in children and adolescents, because again, as I said, the earlier we identify this, the better the long-term outcomes. We need to do things like work more at, right now, FASD would be under, in school in the US would be under 504, a 504 plan, but it's not specified specifically, and it should be. We should have that specifically labeled as a diagnostic term. Of course, most of these kids aren't going to be diagnosed. But then referring the child for an assessment for early intervention, because we know that they often have problems with speech. They have problems often with motor movement, which is a brain issue, fine and gross motor coordination problems, balance problems. So getting them involved with early physical therapy, occupational therapy, and speech and language is really essential. And we know that if they get involved in EI, early intervention, they have better outcomes. And that's 0 to 3. So we need to identify them as early as we can. And again, my bias is any child with a probable FASD should be eligible for early intervention services because they are all at risk of a delay. They may not have a delay yet, but they're at risk of a delay, and that should be enough to get them those services. Can also refer the child for a diagnostic evaluation where it's available and we can get it. And depending on where the child is living and what information we have, do they have the right information, and can the family afford it? Because diagnostic evaluation is rather expensive, and how much is covered by insurance and what's not covered. Things like neuropsychological testing is really an important component of it. And again, speech and language, OT, PT, all of that is really an important part of a really good diagnostic workup. And then also, if we begin to recognize it as probable with the child or adolescent, then we can start to educate families in understanding FASD and how best to support their child, and helping families understand the behaviors that we're seeing and why we're seeing them. That this is a brain-based issue. This is not a willful behavior issue. So our approach needs to be different. So providing some education to families around FASD, I think, is really important. One of the things in my job when I was at the FASD Center for Excellence, 2 colleagues of mine and I wrote an article for the Journal of Psychiatry and Law on adoption, the importance of adoption, of disclosure in adoption. And back then, and it's been a few years since we wrote that, in investigating it, I found that out of all of the 50 states, there were only 11 states that in their adoption statutes had something that said, if an adoption worker knows about prenatal substance exposure, they should share that information with prospective parents. And note this was the language. If they know, they should share it. Doesn't mean that they have to. And there was only 1 state back then that said that adoption workers had to investigate possible prenatal substance exposure. Because what happens is, if not, then families get these kids, and these kids don't respond the way their other kids have, don't respond the way, maybe if it's in foster care, where the foster parents' birth kids did or other foster kids did, and they are at high risk for repeated abuse. And there were at least 10 kids who had been adopted from Russia who were murdered by their adoptive parents. And not because their adoptive parents were murderers, but because their adoptive parents got these kids home, really wanted these nice, polite kids, got them home, and these kids were hellions. And these parents had no idea what they were dealing with. Much, much more important to know what you're getting into and what you're dealing with. And I've gotten calls from people saying, I'm thinking about adopting this child, or I'm thinking, about adopting these children from Russia. What do I need to know? And I said, you need to go into it thinking that you will most likely have a child with an FASD, and this is what this entails. And, these are wonderful kids to raise, but they are really challenging. But if you know what you're getting into, that's important. If you think you're going to get this kid who's just this wonderful kid and just be like all the other kids, and it's, you're going to be frustrated, and they're going to be frustrated at best. And at worst, other things may happen to these kids. So educating the families is really important. And because these family members have been told, you need to set limits and consequences, and you need to follow through with them. And then also, you may be recognizing the family members who may have an FASD. And that's really important, is the adults who may have an FASD. Because although this is not genetically transmitted, we have seen 4 or 5 or 6 generations of FASD in families. So it may be a parent or a grandparent who is affected, where you can't give them 3 instructions or 5 instructions of what they need to do with their child. And when you do give them those instructions, like I did with those families, they don't follow through, and then we say they're neglectful. You can begin to form trusting relationships with the family. You can begin to educate other providers on what this youth and this family needs, which I think is really important, because it's the other providers who are dealing with these kids. You can arrange for warm handoffs, because cold handoffs never work. They need to know who they're going to be seeing, and ideally get to see that person, even in terms of school. If they're going to a different class, to a different school, the ideal would be for them to meet that teacher beforehand, so they know who they're seeing. If there's going to be they're going to be in some kind of treatment, to meet the treatment people ahead of time. If they're going to be transferred from one system to another, those warm handoffs, as opposed to here's an appointment card, or here's a phone number to call to make an appointment.
Hey, Dan,
Yeah.
a quick question for you. Related to education, there was a question related actually to is FASD directly related to the mother and the alcohol consumption? And is there any relation to the paternal end of it?
Another great question. I might have this a little bit later, but I will answer it now. Is that the way FASD is defined now? It's caused by the direct effects of alcohol on the developing fetus. So it's the alcohol that crosses the blood-brain and placental barrier, gets into the developing fetus, that causes an FASD. With that definition, it is the mother consuming alcohol during her pregnancy, even before she knows that she's pregnant. And with that definition, then, the father drinking before conception would not cause an FASD if the mother didn't drink during pregnancy. However, there is some research that's showing that if men drink before conception, that can cause fetal malformations. That alcohol is a teratogen, and a teratogen is a substance that can cause fetal malformations. It's one of the strongest teratogens around. Of course, it's a legal teratogen. So the fact that it could potentially cause genetic mutations in the sperm makes some sense. Now, 20 years ago, some of the experts in the field were saying, no, there's no identification of any genetic mutations. But again, we've learned a whole lot more. So I believe that, so that's one piece. Another piece is that there is a field called epigenetics, where we used to think that, we did the genome project and mapped the genes on the 26 pairs of chromosomes. And we thought once we did the genome project, we were done and we know where the genes are and what's going on. Well, it's not as easy as that. Nothing's as simple as that when it comes to the human brain and the human body. Because it's not just that genes are transmitted from one generation to another, but there are things that are transmitted that turn genes on or off. So we have genes that are working, we have genes that aren't working. And there are some things that can skip generations that can turn genes on or off. So one of the things that's been found in some early research was that, for example, that we have a gene for a bitter taste to alcohol. So if any of you have tasted especially hard liquor as a kid or a young adolescent, the initial feeling is, oh, that's really bitter. Well, that gene tends to be turned off if there's been a lot of alcohol exposure, either from the parents or the grandparents. And that's an epigenetic principle. And if that gene is turned off, it could put the person at higher risk for using alcohol and the effects of alcohol. Now, so that's another piece there. So my belief is, and I might be totally wrong, but I really believe that in the next 5 or 10 years, we may well change our definition of FASD to include men drinking before conception. And it would really be men drinking in about the 24 hours before conception, because sperm doesn't live very long. So it's that drinking right before conception. Well, you know, what happens a lot with unplanned pregnancies, especially, right? People are going out, they're partying, they're having lots of drinks, they're getting drunk, and then they have unprotected sex. So that's exactly the time when men are drinking a lot. So, you know, that was a great question. And again, as of today, FASD is caused by the woman consuming alcohol, but I've heard so much over the years about, you know, I didn't drink at all during my entire pregnancy, but my partner drank before I got pregnant. So I really think that we may change the definition. That's my thinking. I might be totally off base, but again, a great question. So for right now, it's the alcohol that crosses the blood-brain and placental barrier, gets into the developing fetus. And the molecule of alcohol seems to cross the blood-brain and placental barrier easier than other drugs of abuse, and exquisitely targets the developing brain in the way other drugs of abuse don't. So, good question. Okay. Right. So also, you know, anyone working in child serving systems or adult serving systems, actually, you know, you also have the ability to identify women who are at risk of an alcohol-exposed pregnancy, and prevention is so important. As I said, if it costs $1.5 million to $5 million US to raise an individual with an FASD, anything we do in terms of prevention, no matter how much it costs, is cost effective. So talking with families about the importance of abstaining from alcohol. And what we used to say at the FASD Center for Excellence was, if you are pregnant, if you are thinking of getting pregnant, or if you have been in a situation where you might have gotten pregnant, don't drink until you're sure that you're not pregnant. So this is one of the few birth defects that really is 100% preventable. Again, there's no known safe amount of alcohol to use during pregnancy. There's no known safe time during pregnancy to use alcohol for everybody. So the idea that as long as you don't drink in the first trimester, you're fine. As long as you only drink in the third trimester, you're fine. That's not true for everybody, because the brain is developing really rapidly all the way through pregnancy. So at any point during pregnancy, the alcohol can cause damage, and it causes different kinds of damage at different times during pregnancy. You know, and one of the things I remember when I was in college, friends of mine would come home, they would have gone to the bar and they came home and they said, oh my God, I drank so much last night. I was killing my brain cells. And now we know that's true, because that's one of the things that alcohol does. It kills off brain cells, and especially in brain development, kills off a lot of brain cells. So, and as I said, of all the drugs of abuse, crack, cocaine, meth, heroin, alcohol by far causes the most serious neurobehavioral effects. It doesn't mean that those other drugs are okay to use during pregnancy, because they're not. But alcohol is our legal drug. And a colleague of mine who coordinated all women's treatment programs for one of the states, was sitting in a recovery program with a group of women in treatment. And she was just listening to them, and they were talking with each other and saying, you know, if you get pregnant, you have to stop using meth. You have to get off crack. And if you need to use anything, just drink. Because the feeling was alcohol's legal, it's got to be safer. And then there's now new research, because we're moving all over the country, including Pennsylvania, to the idea of legalizing marijuana. And I don't hear anybody talking about, but not while you're pregnant. And we should be talking about that, but not while you're pregnant. Just like we should be talking about that with alcohol, but not while you're pregnant. Because some research is showing that adding cannabinoids, which is a substance in marijuana, to even low levels of alcohol significantly increase the effects of alcohol on the offspring. And that's my concern, is that now we're going to have two legal drugs. People are going to think that they're both safe, and it's okay to use both of them while you're pregnant. And you combine them, and that can cause a lot of problems. And again, the first few weeks of fetal development are really critical, long before women know that they're pregnant. A lot goes on before even the first missed period in terms of embryonic development. And what happens then is that, so this is not a matter of guilt or shame or blame or judgment. And we have so much stigma around this that we have to get rid of, because really that's important. There's so much stigma that's preventing us from really dealing with this openly. And we have to, it's ridiculous. In 40 years, I never had a woman come up to me and say, the reason I drank during my pregnancy was because I wanted to give birth to a child with fetal alcohol syndrome. And again, this is not only women who have alcoholism. This is also women who are social drinkers, who don't drink at all during the week, have a very responsible job. Maybe on a Friday night, they go to the bar with a couple of friends and have a couple of Long Island iced teas. Maybe on a Saturday, they go to a party and have a couple of apple teenies or lemon teenies or chocolatinis or whatever the latest martini is. They don't drink at all on Sunday. They don't drink during the week. But if they may be pregnant, that can cause damage to the fetus, to their unborn child. So it's not a matter of purposeful behavior to harm their child. Nobody drinks during their pregnancy to harm their child. So we have to just, let go of that stigma that we have. And again, it's often before women know that they're pregnant. So I would not ask a woman, if we're trying to figure out whether her child may have an FASD, I would never ask a woman, did you drink while you were pregnant? Because the answer is going to be no, absolutely not. I mean, if you ask it that way, then you have to say, when did you realize you were pregnant? But I would say, lots of us celebrate things in our lives. We celebrate birthdays, holidays, anniversaries, weddings, engagements, vacations. And in our society, when we celebrate things, we often have a few drinks. So if you can think back to the 3 or 4 months before you became pregnant, what were you celebrating? Because that's early pregnancy for most. And then it helps reduce some of that stigma. Because it's so important to know, did this woman consume alcohol even before she knew she was pregnant? Because the earlier we realize this may be one of the things that's going on with their child, then we can intervene with how do we help them best. And that's the goal. The goal is not to blame anybody. The goal, and when there are some states that have floated bills to put people in jail, women in jail who are found using substances during their pregnancy, and that's not going to help anybody. It's not going to help those women. It's not going to help their kids, really. And it's not going to help anybody then, if that's your fear, that if you admit that you were drinking during your pregnancy, either you're going to end up in jail or your kids are going to be taken away from you, then don't admit to it. And then we don't get that information that's so important. And still, almost 50% of pregnancies are unplanned. So if it's unplanned and you don't recognize you're first pregnant, then, again, that's why I think we see some of the rates that we do. And it occurs in any community where women drink. I started out when I worked in HIV and AIDS. I worked in HIV and AIDS at the beginning of what we call the AIDS epidemic. And we had identified 4 high-risk populations for AIDS. And that's what we talked about, the high-risk populations for AIDS. And the high-risk populations for AIDS were gay men, IV drug users, people who got blood transfusions, and especially people with hemophilia, and Haitians, people from Haiti. And we know that one of the groups with the highest increases in AIDS cases over the last 20 years or so has been heterosexual women. And maybe part of the reason for that is we said, you don't have to worry about it. If you're not a gay man, you're not an IV drug user, you haven't gotten blood transfusions, you don't have hemophilia, and you're not Haitian, you don't have to worry about it. So what we did in HIV and AIDS is we changed our language. And we stopped talking about high-risk populations and we started talking about high-risk behaviors. So sharing needles and having unprotected sex is high-risk behavior for HIV infection. In FASD, we did the same thing we did in AIDS, because the early studies were done in Native communities in the US. And in those Native communities, they're the only ones who said, we have a problem, we need help. And when Phil May and the other researchers went to upper and middle and upper class communities and spoke with physicians about wanting to intervene, wanting to interview their women about their alcohol use, the physicians refused. So then people thought, well, this is just a Native problem. And I'm not Native, I don't work with Native people, I don't have to worry about it. This occurs in any community where women drink. And I will tell you that in many middle and upper class communities, where maybe women are social drinkers, maybe women are drinking, and physicians aren't asking them, those kids are being diagnosed with autism, high functioning autism, ADHD, or maybe oppositional defiant disorder. So it occurs in any community. And I talked about men's role. And this is just a little bit about Phil May presented this last November. We were doing a conference in North Carolina, well, a virtual conference in North Carolina. And he shared this. And again, what you look at is those mothers who gave birth to children with an FASD recognize their pregnancies later than the controls did. So again, if they're recognizing their pregnancy at 8 weeks, that's already about day 42 of embryonic development, where a lot has gone on. And then they're recognizing, oh, I'm pregnant, I better stop drinking. Well, but there's been 42 days of possible exposure before then. Now, the good thing is that because the brain is developing rapidly all the way through pregnancy, at any point during pregnancy, if a woman stops drinking, it's going to be beneficial to the fetus, to the unborn child, because it's going to help improve the outcomes. So it's not like, oh, I found out I'm pregnant, I was drinking, I might as well continue. And a lot of our funding, especially from the federal level in the last couple of years, has been around opioid addiction. And you look at the difference between opioid addiction, the number of people with opioid addiction, and the number of people using alcohol. Not everybody using alcohol has a problem with it, but there's so much more alcohol use. And so where's the money to address alcohol misuse and FASD? It's not there because it's all going to opioids, and the programs that are getting that are saying, we can't talk about FASD because we can only talk about opioids. And also, most people who use illegal drugs also use alcohol. And again, the alcohol isn't seen as the problem if they're using illegal drugs. But if they may be pregnant, alcohol is part of a huge issue. And then during the pandemic, I think we're going to see more FASD because there's more drinking during the day. There's lots of things on social media about parents having their kids home. You need a break, just lock yourself in the bathroom with a bottle of wine. And I've seen those things, and having Zoom happy hours. And this said, the fact that there was a 54% increase in national sales of alcohol between the week of March 21st, 2020, which was only the beginning of the pandemic, compared to a year earlier, and a 262% increase in online sales of alcohol between 2019 and 2020. So more alcohol use, more drinking during the day, and more of this, it's okay to drink. Oh yeah, please, you need a break and you need to just calm down, just have a few drinks. So there are 3 promising practices for the prevention of alcohol-exposed pregnancies. Now I know in Pennsylvania, we don't use any of these, I'm not quite sure why, because again, any of them would be cost effective. But Choices was a CDC funded program initially. Now it's out there and it's manualized and it's free of charge and it's available. The manual is available, downloadable from the CDC website. It's 4 motivational interviewing sessions and 1 family planning session for non-pregnant women at risk of an alcohol-exposed pregnancy. So it's women who are drinking at risk levels, which has been 7 or more drinks a week, or at least 1 binge, which is 4 or more standard drinks for a woman within a 2-hour period, and or not using consistently effective contraception. So the goal is to increase effective contraception, decrease risk drinking, or both. And it's been effective for about 2/3 of the women. It's not going to be terribly effective for women who themselves have an FASD, because it's too much of a verbal brief approach. Screening and brief intervention is the idea of for women who are pregnant, screening them for alcohol use. If they screen positive, offering to provide them with a 5 to 15-minute intervention. I just want to share some factual information about the effects of alcohol on an unborn child while somebody is pregnant. And at the Center for Excellence, when we had funding, we funded WIC clinics and Healthy Start programs to implement screening and brief intervention within their programs. And they found that 93% of the women who received this intervention either stopped drinking or cut down during the rest of their pregnancy. Very effective and very cost effective. And the third is the Parent-Child Assistance, or PCAP program, which is a 3-year case management model for women at risk that was developed at the University of Washington back in 1991 by Therese Grant. And Therese has kept such wonderful outcome data and found that these women who had often given birth to multiple children with an FASD either did not get pregnant again or did not use during their ensuing pregnancy. So again, as much as you can say, this saved the birth of children with an FASD, which meant it saved between $1.5 million and $5 million for each one. It's a very, very cost-effective program. All of these are cost-effective if we use them.
Dan,
Yeah.
quick question for you. Going back to the idea of the pandemic and that kind of increase in drinking, knowing that we're very early into this, do you know if there has been any studies that have come out recently that are showing any changes or information on that yet?
No, I don't know of any studies that are being done on that yet. It'll be interesting to see if there are any, but so far there haven't been that I know of. At least nothing has come out in terms of that.
And one more quick question. I have a couple here that I'm going to try to get into later. Is there any studies or causal effects with FASD and breastfeeding?
Great question. There have been studies around that. We know that alcohol is transmitted through breast milk. We know that the brain is still developing rapidly after birth, and alcohol can potentially have an effect on that developing brain after birth. Again, if the way we have it now, if a woman did not drink during her entire pregnancy, but then drank while she was breastfeeding and caused some problems for the child, it wouldn't be an FASD, but it could affect that developing brain. The estimates from research are that alcohol stays in the breast milk for about 2 hours. So the recommendation from many is either, don't breastfeed right after you drink. If you have to drink, then drink after you breastfeed. Don't drink right before you breastfeed. If you need to have something to drink after you breastfeed, or pump and dump, because there's a huge push to increase women breastfeeding, because we know that it improves health outcomes for the next generation. But some are really reluctant to talk about, but not if you're drinking. And the best thing to do if you're breastfeeding is not to drink. And if you cannot stop drinking and you do drink frequently, then it's probably better not to breastfeed. That's at least my recommendation, because again, is it worth the risk? Because there is a risk. Now, it might not have an effect, but it might. But again, it seems that it's about 2 hours that it stays in breast milk. So if there's that space of time, as long as there's not been a lot of alcohol, because remember, the alcohol is metabolizing to an active substance and it's staying in the body longer. So great question. And yeah, at least there has been research. And there's also this myth that's been out there for years and years and years that women should be drinking, especially beer, while they're breastfeeding because it increases the expression of breast milk. And actually, what the research shows is that what it does is it actually increases prolactin levels, which increases the sense in women that they're lactating more. But actually, what it does is shrink the vessels, and actually, the infant is getting less breast milk. So it doesn't even work. But that is a myth that's out there, that it's important to drink while you're breastfeeding, but that's not the reality. So another great question.
All right. Well, thank you.
Anything else?
We have
at
about
this
40
point?
minutes left. Yep.
Okay.
I have a couple more that I'll get into.
Okay. So this is just anything that contains alcohol can potentially cause damage. The thing I like about this study by Kaskutis and Graves, and it's an old one, but they looked at 321 women who were pregnant. These were not women with alcoholism. And they gave them different sizes of drinks and asked them to estimate what the size of that drink was. And what these women thought was one standard drink of hard liquor was actually 6 standard drinks. So again, you hear from maybe your obstetrician or from someone else, it's okay to drink once in a while, and they go out and they have a drink like a Long Island iced tea, and they think they're having a standard drink. A Long Island iced tea is not a standard drink. 40-ounce Foster's is not a standard can of beer. Now they have fortified wine and fortified beer, which has more alcohol content. So, but again, so that most people significantly underestimate the size of their drinks. They'll fill their balloon glass with wine and they think they're having a glass of wine. And they're really probably having a binge in that one glass of wine. So I think that's another issue, is that, again, not willful, not purposeful, not women with alcoholism who are trying to hide the amount they drink, but just that estimate they think that this is a drink. And if you went into a restaurant and ordered a glass of wine and they came with this nice big balloon glass and filled it with a standard drink, you would probably get really angry that you're being cheated because it looks like so little. So why do we need to identify these kids or adolescents or adults? Well, because if we don't identify them, they end up being moved a lot as kids from place to place to place to place. I remember a 14-year-old who was in his 27th foster home. Not unusual for a kid with especially an unrecognized FASD, because we don't train foster parents enough to understand FASD and how it may be different than other kids they've had in their home. They are at high risk for abuse and trauma. This is why if you're working with older kids, adolescents, or adults, asking about their early history and who helped raise you and who raised you and where did you live growing up is really important. And seeing how many different, not how many times did the family move, but how many different caregivers did they have? And they are at high risk for repeated abuse and trauma if we don't recognize this for a number of reasons. As infants, and toddlers, they are really difficult to raise. They often don't eat well. They're seen as very picky eaters. They may have poor sucking reflex. They may be failure to thrive and be in and out of the hospital. If you're trying to breastfeed, they may not breastfeed well because they can't suck. And then they're seen as they get older and they're eating food, they're spitting a lot of food out. And it may be the temperatures or the textures or tastes of certain foods that they can't tolerate, but they're just seen as picky eaters or very, very slow eaters or very, very fast eaters. And it's often the two extremes. Also, they don't sleep well either. They don't get to sleep and they don't stay asleep as they get a little bit older and they're supposed to sleep more. They don't do that, but they're crying a lot. And then they don't like to be picked up and soothed, and they don't get calm that way. And they may cry for hours, and it's just overwhelming, even if parents have no issues of their own. So these kids are at higher risk for abuse because of that. And then as they get older, they don't recognize dangerous people in dangerous situations. And they get themselves in dangerous situations. And you say to them, don't talk to strangers. And then you find them talking to a stranger and you say, why didn't I tell you not to talk to strangers? And they say, yes. Well, then why were you talking to that stranger? Oh, he wasn't a stranger. He told me his name was John. And as soon as somebody tells them their name, they're not only not a stranger, they're their best friend. So because they don't recognize danger, they put themselves at high risk as they get older for repeated abuse and trauma. They fail with our typical approaches if we don't recognize them. They don't understand why they keep failing, and they start to think that they must just be bad or stupid. And what I've heard a lot from adults who have gotten a diagnosis of an FASD, the first thing they'll say is, at least now I know I'm not just bad, or at least now I know I'm not just stupid, because that's what they have felt for years and years and years, because they don't understand why they keep failing, why they keep screwing up. And they are at high risk of ending up repeatedly homeless, repeatedly in jail, or dead. And that's why we need to recognize them. And again, the earlier we recognize them, the better the outcomes. And then, as I said earlier, we don't recognize it in the adults, in the caregivers. So, again, Child Protective Services may be called for potential abuse or neglect, and they go in and they take the child and place the child in kinship care or foster care, and then may say to the parent, do you want your child back? Yes, I want my child back. I love my child. Okay, here's what you need to do to get your child back. And they give the parent a list of 7 instructions or 18 instructions of what they need to do, when their appointments are, when they need to call their child in the foster home, when they need to visit. And then I always talk with foster parents and say, do you ever have families who, instead of calling like at 6 o'clock on Tuesday and Thursday, they call Wednesday at 7 in the morning or at 10 o'clock at night, and they have a visit on a Saturday morning, and instead they show up Sunday afternoon or Monday, and they all laugh because they've all had that experience. And then what we say is we have this federal initiative for permanency planning, so we need to terminate parental rights. And I was working with a program, and they were working with a young woman who was pregnant for the 3rd time, and her first 2 kids had been removed from her care permanently. And the worker said to her the week before I got there, he said, why do you keep getting pregnant? And she said, because you keep taking my children away from me, and I want a child to raise. And I said to them, if you had intervened with her first child and done whatever it cost to be a successful parent, if that cost less than $4.5 million just for that one family, that would have been cost effective. Because now there will be 3 kids, all with an FASD, at a minimum cost of $4.5 million, $1.5 million each. I said, do you think you could have come up with something for less than $4.5 million for her? I think you could, because she really wanted to parent a child. And I said, the best thing you could do is take her now, while she's pregnant with her 3rd child, and place her in a family foster home where you have trained the foster parents that their role is to work with the parent and the child, who can stay in that foster home as long as they need to. Because remember, I said at the beginning this afternoon that those with an FASD learn best by modeling the behavior of those around them. So they're in this foster home, the infant is born, this infant is crying, and the foster parent can say, let's check and see if she's wet. Let's check and see if she's hungry. And that's how this parent can learn to be a successful parent. And if it takes 2 years, 5 years, doesn't matter. No matter how long it takes and how much you pay that foster family, because you need to train them, you need to supervise them, and you need to pay them, it is cost effective, because then they won't have another child. There was an example of a family that I had heard about and talked with the agency working with them. And it was a mother who had an FASD herself, and she had 2 kids, both with an FASD. So her mother drank during her pregnancy with her. She drank during both of her pregnancies. She loved her kids, and she wanted to do the best for her kids. And this agency had been working with her in terms of, keeping her kids at home and helping her with that. And they were at the point where they said, anytime you have a question, you call me, one of the workers. And if I'm not available, you call her, another one of the workers, and both of us, and you feel comfortable with both of us. And so this mother would call sometimes and say, it's 5 below zero, which coat should I give my son to wear? And they would say, well, what do you think? And most of the time she would say, she would have the right answer. And they never said, well, then you don't have to call about that anymore, because that would have been a mistake. They said, I think you're absolutely right. Or she would call and say, my daughter came home with her math homework. I don't know. I don't understand it. What do I do? By having that set up, anytime you need to talk, you call me or you call this person. If I'm not available, not call the agency and talk to whoever's on call, because they wouldn't do that. She wouldn't do that. She kept her kids at home. They weren't in foster care. They weren't moved from place to place to place. And she was successful as a parent. So again, it's just recognizing, how do we help them? Now people have said to me, can everybody with an FASD be a successful parent? I said, no, probably not. But can everybody without an FASD be a successful parent? No. So I don't think there's one excludes the other. But those with an FASD often really do love their kids and really want to be a good parent and need the right supports in order to do that. So if we recognize the person as having an FASD, we recognize them as having a disability, because again, those with full fetal alcohol syndrome and with a lower IQ do much better than those with a higher IQ who maybe have alcohol-related neurodevelopmental disorder. Because again, you have an IQ of 120, you're verbal, you're bright, you can tell the person what you need to do. Obviously, your behavior is purposeful, and then the expectations of that person are much higher. But if we recognize them as having an FASD, we say, this is a person with a disability. So we can reduce some of our frustration and anger in dealing with them, because they keep repeating the same negative behavior over and over again. But if you recognize what's going on, you can say, oh yeah, that's right. That's a brain issue. That's not a willful behavior issue. We can reduce abuse and trauma if we recognize that they don't recognize danger. We need to really think about different situations they may get into and model for them how we want them to act in those situations. And then we can modify what we do if we recognize FASD, and we can maybe question some of the diagnoses they've gotten over the years. Because typically what happens is, you see a provider, you get a diagnosis, you see another provider, you get another diagnosis. And I've seen kids at 10 or 11 years old who have 4 or 5 different diagnoses and maybe are on 7 medications, because each time you add another medication. And nobody's ever questioned the diagnosis to say, is this an accurate diagnosis? Or may this be something else? So unfortunately, there's no easy way to identify somebody with an FASD. You can't just do a blood test. So we needed to develop some type of assessment protocol to identify those with a probable FASD, because diagnostic capacity is so limited. And the gold standard is, you screen somebody, you assess them, you say this is a probable FASD, you refer them for a diagnostic evaluation. That is the gold standard which we want to have. But we can't wait for that to intervene and change what we do, because if we do that, we are putting them at risk of ending up homeless, in jail, or dead, no matter what age they are. So we developed a screen that leads to a more thorough assessment that should lead to that. What happened was that I was working with some treatment programs in 3 different states, and they said, and trying to get them to recognize the adults who may have an FASD, because having raised Bill, it was, that on a federal level, if anybody talks about interventions in FASD at all, they talk about children. And I'm always the one to say, well, what about the adolescents and adults? This doesn't go away. So I wanted them to recognize adults who are in treatment, who are keep failing, who may have an FASD. So once they began to see some of those people and say, oh yeah, that's why they're doing what they're doing. That's why they keep messing up like this, and they keep apologizing, but they keep on messing up. They said, well, okay, how can we identify them? So I contacted my two friends and colleagues at the University of Washington, And together we developed a screen called the Life History Screen. And we ended up with about 32 questions in 9 categories. And the information on the development of the screen and the analysis and statistical analyses was published here in the International Journal of Alcohol and Drug Research. And the idea of this screen was to identify this was older adolescents and adults who may have an FASD, and then be able to intervene by doing something different with them. And first we developed the screen, then I gave it to 22 different treatment centers, got feedback from them. We changed some of the questions, changed some of the language. They told us what the most important categories were, the most useful. And then we, published it. And so the concept is that it's to be given to everybody because we don't know who may be affected and who may not. But it's not handed out to a person, say, complete this. I don't hand it out to people because people around the world have said, can we get a copy of it? And I say, no. Does it cost money to use it? No, but you need to be trained in using it because it's not something that you put on a computer and have somebody sit in front of it and answer, or send it out and have them answer it, or read the questions the way they are written. Because sometimes you're asking questions of a person who may have an FASD, you need to explain the questions. You need to be comfortable in how you discuss this and how you talk about it and how you get the information. So how you ask the questions, when you ask the questions, how you form a trusting relationship, all of that is really important in terms of that. And then the state of Michigan, their Department of Health and Human Services, Mental Health Services to Children and Families, wanted to develop a screening and assessment protocol for children and adolescents. So I looked at, we developed a quick 4 or 5 question screen that an intake person could do. And then a positive screen would then lead to an FASD trained clinician to do an assessment. And the assessment is based on the life history screen. I modified it for birth to 5 and 6 to 18 because other screens I looked at, I wasn't really happy with. Some of them were just too broad, didn't really pick up enough of those youth who may have an FASD. So I modified the life history screen. And we've been doing it now in several counties. It started as a pilot and now it's a project in 6 or 7 counties for their public mental health. Sorry. So that's been exciting because now we have this protocol from birth to adulthood. And again, the idea is if you're not going to do anything different with the results of the assessment or screen or assessment, then don't bother doing it. So I think it's been really helpful. I think we need to identify this. And actually a study was done in Germany to look at the screen and validate it. And they found that it was about almost 93%, was actually 92.8% accurate in identifying those with and without an FASD, which is pretty good. To be almost 93% accurate in just doing this, again, it's not diagnostic, but it's pretty close. And if we can say this is almost 93% accurate in identifying those with an FASD or without, then that's when we need to intervene and change what we do. So,
Dan, with that, there's a question is, can a neuropsychologist or neurologist properly diagnose FASD?
Another good question. Neuropsychologist is really useful, but part of the diagnosis has to be a physician because there's still that medical piece of looking at the facial features and doing the physical exam. That's a really important part of the diagnosis. Now, there is a group of psychologists who have been doing studies looking at neuropsychological testing and finding certain subtests scatter in neuropsychological testing that seems to be indicative or common in those with an FASD compared to controls. About 22 subtests were different in controls and those with an FASD. And then they looked at ones who were, then they looked at FASD compared to ADHD, and they still found a number of subtests that were significantly different in those two groups. And I haven't I have to touch base with them and see if there's been any update in their studies, if they've done any more, because I was really hoping that if they continued with that, that maybe at some point neuropsychological testing would be diagnostic. We're not there yet. I mean, it's a very, very important component of a diagnostic process, but it's not by itself, it's not diagnostic.
Thank you.
Okay. So having been dealing with this for such a long time, I thought, why are we so resistant to recognizing the impact of FASD? And I really think it's this, or at least partly. It challenges the basic tenets of everything we've been taught as a parent and as a professional, because we have been taught that people need to take responsibility for their actions and learn by experiencing the consequences of their actions. That works with a lot of people, but that does not work with a lot of people with an FASD. But it's hard to let go of the fact that not everybody learns by experiencing the consequences of their actions. We also think that people are in control of their behavior, meaning they can choose to do the right thing when they want to. When they are ready, then they will respond to our approach. Then they will do what they need to do. If they are ready, and we find the right motivating factor, then they'll do what they need to do to get that motivating factor. Works with some people, doesn't work with a lot of people with an FASD, because they really do want to do the right thing and they can't do it on their own without support, which is why we have to modify the environment. And then we think if we do things for them, then we're just enabling and fostering dependency, and that's bad. And because they need to do, and I've heard this so often, especially with adolescents and young adults, they need to learn to do these things on their own because that's the real world. My response is always, if they could do it on their own, they wouldn't need our services. And while they have our services, we need to provide what they need. And fostering a sense of dependency is actually a good thing, not a bad thing, because people can't take positive risks if they don't know that there's somebody they can count on if they trip up. And then if we recognize FASD, we have to deal with our own values and biases about behaviors, about drinking during pregnancy, that all behavior is willful and purposeful, that women just drink during pregnancy to harm their child. It may bring up issues in our own lives that we don't want to look at, that maybe there are people in our family who may be affected, and we don't want to look at that, so we don't deal with it. It also means we need to change what we do, and it's better. This is what I was taught. This is what I need to do. And it's so much easier. Having been a direct care provider, I know this. It is so much easier to say, when this person is ready, they will respond to our approach. And at one point I wrote what I called my paradigm shift, which is we have to move from viewing the person as failing if they don't do well in a program to viewing the program as not providing what they need in order to succeed. So if somebody is in an approach that works with a lot of people and is not working with them, if a treatment is not working with them, don't give them more of the same treatment, which means if reward and consequence isn't working, don't give them more reward and consequence. But maybe we need to do something different. If they're back in treatment for the third time, maybe we need to say, what do we need to do differently to help them succeed? Rather than when they're ready, they will respond, which is often our typical approach. And then we think we need to treat everybody the same in order to be fair. And I will tell you, it is so much easier to treat everybody the same. Here are the rules. Here's what happens if you break the rules, period. So this is just a graphic that actually was shared. I saw it first that it was shared by the Secretary of Health for the state of Minnesota at a conference several years ago. And I really liked it because on the left-hand side is treating everybody the same. So these three kids who all want to watch the baseball game, they all get the same size box to stand on. Unfortunately, this little kid can't watch the game. He's too small. On the right is treating everybody fairly, which means everybody gets to watch the game with whatever it takes. It is so much easier to treat everybody the same, but that's not being fair because everybody is dealing with different issues. And we need to look at each person and say, what does this person need in order to succeed? And people will say, but I'll get nailed for that. If I try to treat this person differently than this person, or my one kid differently than my other kid, they're going to come at me and they're going to say, you're not being fair. And the response is, I really am trying to be fair because I'm looking at each of you with what you need. And you may think that I let him get away with things that I don't let you get away with, but you're able to do things that he has different difficulty with. And it's not a matter of talking about diagnosis. It's a matter of trying to be fair. And what does each of you need in order to be successful? And that's what we're trying to help you with. But treating everybody the same is so much easier. So we need to rethink the concept of dependency and enabling as bad, because I would hope that everybody is enabling the people they come into contact with to succeed with whatever it takes. Yes, enabling has some negative connotations, which we need to avoid, but for the most part, we want to enable people to be successful. And then treatment of co-occurring issues needs to be different if there's an FASD. So if we get people to even recognize FASD as an issue, this is how they look at it. So maybe they have bipolar disorder and an FASD. Maybe they have a learning disability, and we'll just treat them all, but we really treat them separately. We treat them in parallel, because that's what we tend to do in mental health. Treat them in parallel. When it comes to FASD, this isn't the right approach. When it comes to FASD, this is a much more effective approach. So if they happen to have bipolar disorder and they have an FASD, we can't use cognitive behavioral therapy the way it was developed and give them their medications. We need to modify the treatment. If they have a learning disability and an FASD, we have to approach the learning disability differently because of the FASD. If they happen to be homeless as an adult, we can't just find housing for them and then say, now you have to pay your rent the 10th of every month. You have to meet with the housing director once a week. You can't have any drugs or alcohol or other drugs in your housing, because the 10th of the month will come. They have no money to pay their rent because they spent it all early in the month, and then they will get evicted. Then they'll learn to save their money and pay their rent. No, they won't. Because the FASD tells us whatever you're dealing with, you have to think about the brain is processing information differently. So our approach needs to be modified. So these are likely co-occurring disorders with an FASD. ADHD, schizophrenia, depression, bipolar disorder, we may see as co-occurring. Substance use disorders, but if they are truly co-occurring, our approach to them needs to be modified. Other likely co-occurring disorders, sensory integration disorder, again, in all sense areas, certain smells may just set them off, and they just have these tantrums or rages that seem to come out of nowhere. And if we think about it, it may be certain smells, maybe certain foods or other kinds of smells that set them off. So all 5 sense areas are really affected: light, sound, temperature, texture, smell, taste. They may have a co-occurring reactive attachment disorder if they've been moved around a lot, or separation anxiety disorder if they've been moved around a lot. But even if it's co-occurring, our treatment for it needs to be modified. They may have PTSD because of repeated trauma, but again, we can't use trauma-focused cognitive behavioral therapy the way it was developed. We need to modify it. They may have a co-occurring traumatic brain injury because they fall, they hit their head, they suffer a head trauma on top of the FASD, ride their bike into a street, get hit by a car, suffer a blunt head trauma on top of the FASD, get into a fight, get beaten. They're at risk for borderline personality disorder as an adult because one of the risk factors is repeated trauma. And they're 5 to 60 times more likely to have certain medical disorders. So anybody born with a cleft lip or palate, or born with a seizure disorder, we should be talking about whether there was alcohol exposure. It's not the only reason, but it is one of the reasons. Certain atrial or ventral heart abnormalities, scoliosis, curvature of the spine, all kinds of other medical issues, which are more likely with prenatal exposure to alcohol. So just being aware of those, I think, is important. But in addition to the co-occurring disorders, there are a number of misdiagnoses, which kind of look like the co-occurring disorders. So does it matter? If it looks like ADHD, we'll just treat ADHD. If it looks like an oppositional disorder, we'll just treat an oppositional disorder. So from my point of view, it does matter. And Bill taught me that I needed to be more visual, that just talking wasn't enough. So I started doing charts. I have a whole series of them, but I'm just using one. And so I'd like you to think about 3 people, somebody you come into contact with, doesn't matter the age, doesn't matter who they are. You've given them 3 instructions. You've told them 3 things and they haven't done it. Now, the example I will use, because I experienced it so often, was go to your room, pick up your dirty clothes, put them in the hamper, fold your clean clothes and put them away. And you go up to these kids' rooms or adolescents' rooms a half hour later, and all 3 of these adolescents are fooling around, reading a book, watching TV, on the computer, and nothing has been cleaned up. One of them has a true oppositional disorder, one has a true ADHD, and one has a true FASD. The behavior is exactly the same in these 3 individuals. No difference in their behavior. You've given them instructions, multiple instructions, they haven't done it. What we tend to do is go from here's the behavior, here's the consequence for the behavior. That's our reward and consequence approach, right? Here's the rule, you break the rule, here's what happens. And what we don't do enough is stop in this middle row and say, what's causing this behavior? That's essential, is to figure out, you cannot come up with an appropriate intervention for a behavior unless you understand what's causing the behavior. Because the same behavior can have very different causes for different people and can actually have different causes for the same person at different times. So let's look at the person with a true oppositional disorder. If you sit them down and you say, what did I tell you to do? They can tell you what you told them to do because they took the information into their brain, they could store it in their brain properly, and they recalled it when they need it. Then you say, well, then why didn't you do it? I didn't feel like cleaning my room. I didn't want to do it. It's good adolescent, a good oppositional response. If it is truly oppositional, which means it is a conscious decision to not do what they were told to do, then this is where reward and consequence can be effective. First, you give them a positive sense of control. You can do this now or in 5 minutes. Which would you prefer? I don't want to do it now. Okay, I'm going to set the timer for 5 minutes. When the timer goes off, you need to go clean your room. If you clean it, here's the result. If you don't clean it, here's the result. And if they don't like the consequences, eventually they will change their behavior because it is conscious decision. Sit down with the individual with a true ADHD. You might have to help them focus and filter out stimuli, but they can tell you the 3 things you told them to do because they took the information into their brain, stored it properly, and could recall it when they need it. Their problem was that they went up to clean their room. They picked up their dirty clothing to put it in the hamper, and there was a book underneath. They sat down, they started to read the book. The phone rang, they went over to the phone. Their friend was on the phone and said, hey, I'm at the computer. You want to play some computer games? They got distracted. But if you could get them on target, they know the 3 things they need to do. And we do that by limiting stimuli, providing them with cues, and maybe if they can't do it environmentally, they get medication that helps them filter out stimuli and focus so that they know that they remember the 3 things they need to do. Sit down with the individual with a true FASD, and if you ask them the right question, which is, what did I tell you to do? They may say, vacuum the rug, wash the walls, clean the room. I mean, if they get something right, it's a guess because by the time they get up to their room, they have no idea what to do next. Because in FASD, the difficulty is taking information into their brain. Even if it gets into their brain, it doesn't get stored properly. And even if it gets stored, they can't recall it when they need it. So with that, if that's the reason for the behavior, the approach for an oppositional disorder will never work. You could set a timer goes up, they don't know the 3 things they need to do. Even limiting stimuli and providing them with cues isn't going to work because they don't remember the 3 things they need to do, but breaking it down to one direction and one step at a time can be very effective. This is why so many individuals with an FASD get a misdiagnosis of an oppositional disorder, because it looks like they are just being oppositional.
So Dan, you have about 4 minutes left.
I know. You want to go through any questions, or I mean, I can kind of stop at any point.
Any key takeaways? Because I know this is part 1 of the 2-part piece. If you have any kind of key thoughts that you want to take away, I think I have a question or 2 that I can kind of propose to you. One is about resources. where would you find agencies or services for FASD? And that may be a very broad question. I probably should have saved that one to the end.
Yeah, that's a pretty broad question. But I will tell you that, and I think that, we talked before we started about putting up, I have a slide at the end here that I'll make sure it gets up on the website of kind of resources, national resources that really would, may, at least on a US national basis, that to get some information, to get more ideas about what might work. Every state is different in terms of what they have. And, some states have task forces, FASD task forces, which can be really useful in finding specific resources in that state. I know Pennsylvania does, I know Michigan does, I know California has some. The National Organization on FAS, NOFAS, has a lot of statewide affiliates who can be really helpful. So going to there. And I know that also there is a resource guide that was developed years and years ago in FASD with what resources are available in different states. And it is being updated and should be done within the next few months. I'm not sure how it's going to be distributed, but it probably maybe through NOFAS, but I'm not sure about that. So we'll have more about resources, but at least having those resources to check into to start with may be a good start.
Okay. I'm actually going to share that resource page real quick so that people can see it. The other one was have heard that later pregnancies with mothers who drink alcohol are more likely to have FASD. Is there any truth to that?
Yeah, yes. There are a number of things that come into play. The age of the mother, how many live births she's had, what her nutritional status is, what her liver function is. All of those have an effect in terms of the effects on an unborn child. So that's why often we may see that later children, even with the same amount of alcohol exposure, may have, more severe outcomes. So that is true.
All right. I think one of the last questions we have is research around what research is available around paternal drinking's impact with FASD. So I think that's kind of in that general CDC and NIAAH information that we'll share.
Yeah, I think that NIAAA might have some of that, especially.
All right.
Dan, I did put the resources that you provided. There's a link in our chat that'll take you to the pages that you provided for us.
Okay. And actually what I need to do is probably MOFAS, the last one, Minnesota Organization on FAS, again, has a lot of wonderful information on their website, has changed their name to Proof Alliance. But if you do www.mofas.org, you will still get to them.
All right. Well, thank you for the information. You have just an absolute, just amazing information, and it's kind of this. It was really interesting that it's been a long road to get where we are, and it sounds like we're nowhere near the end of it.
Right. Yes. And a friend of mine once, a colleague shared a quote from Winston Churchill, which I think is just spot on, which is, we are not at the end. We are not even at the beginning of the end. We are perhaps at the end of the beginning. And I think that that's where we are in terms of FASD. It's still seen as a pretty new, hasn't been studied that long. I mean, 40 something years is not that long. And, but I think we are at the end of the beginning, which is encouraging, but we still have a long way to go.
All right. So with that, I want to thank everybody for attending today. We are going to be putting in the chat the link for the certificate of attendance, as well as the certificate or the link for the continuing education credits. And it is with our pleasure that we're going to have Dan back on May 27th, starting at 2 p.m., which is improving outcomes by modifying approaches for those with FASD. As a reminder, the continuing education credits, the link will be emailed out tomorrow to those who attended. And those instructions are to get your continuing education credits from UPMC. For those also attending today, you'll have the option to complete a survey at the end of the webinar today, and also an email will be sent out tomorrow where you can complete your survey and also download your certificate of attendance, not the continuing education credits. Our next presentation will be Tuesday, May 11th at 2:30 p.m. And it's our presenter is Dear Adult World, an opportunity to listen, hear, and learn from youth and young adults. So please join us for our next presentation for Mental Health Awareness Month. And then also at the end of the month for our presentation with Dan coming back and really rounding us out on understanding kind of the world of FASD and ultimately where we can go for some treatment modifications and skills. So thank you all and have a fantastic day.
Thank you very much, Mark.